The American Diabetes Association 2023 Standards of Care in Diabetes have been released. Before I start, I want to acknowledge the hard work of the Professional Practice Committee and the ADA CMO, Dr. Robert Gabay. Next, I am going to discuss the section updates that I think are important, and finally, I will describe how I think these guidelines can help in clinical care. Section 1 is entitled Improving Care and Promoting Health in Populations. I work in under-resourced East Los Angeles, and this is a very important topic to me because I want to provide better health care to under-resourced patients. In this particular section, they add in the concept of using community health workers to support the management of diabetes and cardiovascular risk factors. And I think this couldn't be stressed more because these individuals are often the people who best connect with my patients. Section 2 discusses the classification and diagnosis of diabetes, and what's new is that they now say that we can use a point-of-care A1C testing machine to both screen for and diagnose diabetes. I think this is great because I think many of us have been doing this for a while. But I do know that in my office, my point-of-care machine can sometimes seem a little bit buggy. So I want to make sure that everybody calibrates and maintains their machine in good shape so that we're sure that our diagnosis of diabetes is done correctly. The next section is on prevention or delay of type 2 diabetes and associated comorbidities. And here they actually discuss the use of pioglitazone for reducing the risk of stroke or myocardial infarction in people with a history of stroke and evidence of insulin resistance and prediabetes. Section 4 is the comprehensive medical evaluation and assessment of comorbidities. And there are a number of significant changes in this section. First of all, they changed the section on immunizations extensively, in part now because we have the COVID-19 vaccines, and they talk about boosters and use of pneumococcal pneumonia vaccinations as well. There's a whole new subsection that's quite detailed, which discusses non-alcoholic fatty liver disease. And this talks a lot more about the diagnosis and risk stratification in both primary care and diabetes clinics, such as using the Fibrosis 4 index to assess the risk of liver fibrosis. And they also include a Fibrosis 4 index risk calculator. Now, this isn't something that I actually have routinely been doing in my clinic. And so I think it's important to note that this is there. And they also give really helpful guidance. They give a figure and information that's from the American Gastrointestinal Association guidelines to really look at how do we classify this in our patients and then what we should think about and do about this problem. Next, they talk about facilitating positive health behaviors and well-being to improve health outcomes. And in the section on diabetes self-management, education, and support, they talk about social determinants of health in terms of how that guides treatment and DSMES delivery. And they also talk about the use of telehealth delivery of care and other digital health solutions. And they talk about screening for food insecurity. And I think this is particularly important because I actually don't really know about food insecurity unless I ask. And a lot of times patients are shy about telling me that they are having issues with food insecurity, but it matters a lot when you're talking to patients about nutrition and what their barriers are to eating well and managing their diabetes. The subsection that used to be called psychosocial issues is now called psychosocial care. And they really emphasize providing appropriate psychosocial support to patients with diabetes. And we've discussed this many times before, but it's really front and center now. And they also discuss sleep and the concept of discussing with our patients whether they're getting enough sleep and restful sleep in order to manage their diabetes and their lives, frankly, more effectively. In the section on glycemic targets, they talk about changing the targets for those patients with frailty or who are at high risk for hypoglycemia in terms of looking at a target of greater than 50% time in range, which is obviously less than the recommendation for greater than 70% time in range for other individuals, and of less than 1% time below target range in order to really stress the need to prevent hypoglycemia in these patients. Section 7 on diabetes technology is a section near and dear to my heart, and I think they did a great job on updating this section. They updated the recommendations based on all the new data that we have, and trust me, there's lots of new data on technology that comes out every year, and they incorporated all the new references. And in particular, they discussed the use of CGM in people on basal insulin, and they also incorporate all of the new data that we have on AID systems. They add in a new table to address interfering substances with all of the CGM devices, and I find this table quite interesting and useful. They add more data and information about the do-it-yourself hybrid closed-loop systems, and I love that they did this because there are many people who do use these systems and need our support. Then they update the inpatient care subsection to include all of the updated evidence in this area, and they talk about the use of CGM in the inpatient setting that occurred during the COVID-19 pandemic. Section 8 looks at obesity and weight management for the prevention and treatment of type 2 diabetes, and more it is stressed that this is vital to preventing and treating patients with type 2 diabetes. But they also talk about reinforcing that both smaller and larger weight losses are part of our treatment goals, and that we really need to look at patients on a case-by-case basis and make small, appropriate targets and recommendations so that patients can really adhere to what we're suggesting and improve their outcomes. They also discuss using the dual GLP-1 GIP receptor agonist, tirzepatide, as a glucose-lowering option with the potential for the greatest weight loss. Section 9 is entitled Pharmacologic Approaches to Glycemic Treatment. And this is really sort of the headline of the standards of care because everybody looks at this to determine how they should manage glycemia in their patients with type 2 diabetes. And basically, they took the consensus report that was released a few months ago from the ADA and the EASD in terms of the management of patients with type 2 diabetes. I've done a prior video on this, but I suggest everybody make sure that they understand what these guidelines are and look at both Table 9.2 and Figure 9.3, where they go through their recommendations. And I'm going to talk a little bit more about this at the end of the talk. Section 10 is entitled Cardiovascular Disease and Risk Management, and this is the section in which I think the most changes were made. First, they lowered the blood pressure target to less than 130/80, and they update the tables and figures for this lower target. In terms of lipid management, they recommend the use of high-intensity statin therapy in higher risk individuals with diabetes who are aged 40 to 75 to reduce the LDL cholesterol level by greater than or equal to 50% of baseline, or to target an LDL cholesterol of less than 70. They recommend adding ezetimibe or a PCSK9 inhibitor to maximal tolerated statin therapy in individuals who are not reaching their targets. They recommend that in adults with diabetes who are older than 75 years who are on a statin to continue that statin, and that if people aren't yet on a statin, you may want to initiate moderate intensity statin therapy, even in these older individuals. They also discuss treatment with high intensity statin therapy in individuals with diabetes and established cardiovascular disease to target an LDL cholesterol reduction of greater than or equal to 50% from baseline but an LDL cholesterol goal of less than 55. So this is the lowest LDL cholesterol target that we've had, and frankly, it makes a lot of sense in these patients who have existing cardiovascular disease. They add in a recommendation to add finerenone in the treatment of individuals with type 2 diabetes and CKD who have albuminuria treated with maximal tolerated doses of an ACE inhibitor or an ARB. In terms of CKD management, in addition to what I've just mentioned, they talk about adding in an SGLT2 inhibitor if the eGFR is greater than or equal to 20 and the urinary albumin excretion is greater than or equal to 200. They also recommend that adding an SGLT2 inhibitor might be effective in people with CKD and a urinary albumin excretion that is normal to 200. In older adults, they discuss using CGM and other technologies in order to help patients manage their diabetes more effectively and in particular avoid hypoglycemia. They discuss de-intensification of treatment goals to reduce the risk of hypoglycemia if it can be achieved within the patient's individualized target goals. They also discuss simplification of complex treatment plans, especially with regards to insulin, in order to reduce the risk of hypoglycemia and polypharmacy and decrease the burden of disease if it can be achieved within the individual's A1C target. And I must say I spend a lot of time trying to do this in order to make life easier for our patients, and not just in older individuals. I certainly have younger individuals where simple is better. So I think this is a concept that works for almost everybody. We want to make sure people get to their targets, but make it something that is possible for them to achieve. Those are the changes I thought were most important, but there are other changes throughout the guidelines, and I'd encourage you to read them and pick out what's most important to you. But in terms of the overview, how do these guidelines really work? There are two important things. One, I think these guidelines are really great in terms of reducing cardiorenal risk. And they look at patients with established cardiovascular disease, with CKD, with obesity. They do a lot for expanding how we think about people with diabetes and what their risks are. But I think they let us down when it comes to looking at how to manage hyperglycemia. So for instance, if you have a patient who comes in who has pre-existing heart failure or CKD with new onset diabetes, you're not supposed to look at the A1C and you're supposed to start an SGLT2 inhibitor. But if their A1C is 8.5 or 9 and you put them on an SGLT2 inhibitor, you're not going to get them to target. And then if you add in a GLP-1 receptor agonist, which seems like a great idea, you may be able to get them lower, but that's a very expensive combination and frankly, not one that we have good outcomes in terms of whether or not that really adds to the benefit. And so in LA County, where I work, if you look at the data that we can get on patients, we find that probably 35%, maybe 40% of our patients with diabetes have an A1C that's greater than 9. And every time I work in clinic, I see patients with significant nephropathy, retinopathy, and neuropathy, all complications directly related to hyperglycemia. And I can also tell you that my providers in LA County, our wonderful primary care providers, have a lot of trouble in managing hyperglycemia. They're really pretty good at managing lipids. Most patients are on a statin, and they're not so bad at managing hypertension. But when it comes to managing glucose, particularly in patients where it's more complicated rather than simple, it's really difficult. And we've been struggling in the county to write guidelines to teach primary care providers how to manage hyperglycemia in their patients. And it's taken us over a year to make a protocol that makes sense. And yes, we use SGLT2 inhibitors, and yes, we use GLP-1 receptor agonists in the County of Los Angeles, but we have to choose in whom, and we have to choose it based on our formulary and based on what we can reasonably provide to our patients. And I really hope that the American Diabetes Association and everybody who writes these guidelines doesn't forget the need to think about glucose and to provide pathways for patients who don't yet have cardiovascular disease or CKD or heart failure, and help them reach their targets so they don't develop the microvascular complications of diabetes.